Look at this cool thing I found at the Dollar Tree. It's a heart. But it's also a fidget thing. I like it. Okay, so we've got 3 exams next week. I studied for the one I'm worried about this morning. This one is in a class that I have homework due on Monday and the exams on Monday. That should be illegal. Apparently it is not. So we're going to do some pericardial effusion homework first, and then something that I think will be probably more interesting. Maybe not. We're going to edit this document. Yeah. This is pretty neat. This is this is my protocol. That'll be on Wednesday. Then I'll be getting tested on that. That's what I'm worried about. I practiced this morning. I am pretty good, but I am slow. So it's one of those things, you can either have it done fast or you can have it done right. I need to be both fast and right, so we're gonna practice. Yeah, and we're gonna do this chill pulse game, which I enjoy a lot. We've got, oh, you probably can't see this. So we've got lime juice, ginger beer, and dark rum. So we'll do, let's do all 3. Maybe. Oh. There might be a problem with our juicer. We'll try it again. This is a pretty new update, so there might be a bug. Okay. Looks like we might have a bug. Well, that's unfortunate. I wanted to try the drink. They let me do it before with just the ginger. Let's try that again. Oh, there we go. I guess they just don't have something programmed in yet for the other one. Triple ginger beer is for a fiery throat tickling fizz. Ultra refreshing and alcohol free. I guess that is what we should be doing right now. Alright, so she's got her little ginger beer. What is on my shared screen? My homework. Cool. Okay, so what we're going to be doing is filling this out first. Then we're going to double check. And then we are going to put it in there. So. Because I want all of the points. Want them all? Okay. Question number 1. Choose the statement that best describes a pericardial effusion. Abnormal amount or type of fluid around the heart, between the parietal and visceral layers, circumferential versus loculated, or all of the above. I'm thinking it's all of the above. Let's take a look. Pericardial effusion. Oh, it is the first sentence on our textbook here. Presence of an abnormal amount and or type of fluid between the parietal layer and visceral layer of the pericardium. And it could be a local versus systemic disorder. Okay. Got abnormal amount of fluid. Check. Parietal and visceral. Check. Circumferential. That's a weird word. It means around the entire heart, or it could be loculated, meaning it's only around the ventricles. So, and I don't remember what that's called. I mean, it's loculated, but it's like a local thing. So you either have it around just the ventricles, or the ventricles and the atria, and also over the top, everything that the pericardium covers. So I think all of the above is safe for that. Yeah. Local versus circumferential. Beep, boop. Good. Number 2, pericardial effusion can be described as acute versus chronic and local versus systemic. I believe that is true. Acute versus chronic, local versus systemic. Awesome. That is true. Which of the following would most likely cause a small pericardial effusion? Oh, if you're following along, if you somehow have this homework as well, which the chances of that are very low, because this is real specific. I don't know how many people are actually going to school for this right now, but the number is not high. It is very specific, and to have this specific homework right at this moment, very unrealistic to expect that is the case. This is not guaranteed to be the correct answer. I'm just going to throw that out there right now just to cover my own butt. I think it's correct, but definitely double check your stuff. Okay. Which of the following would most likely cause a pericardial effusion? Acute pericarditis, ascending aortic dissection, cardiac perforation, or tuberculosis? Cardiac perforation, I think. Let's see. Nope. Does it say what size? A small pericardial effusion. Acute pericarditis, then. Yep, less than 10 millimeters by echo and 50 to 100 milliliters. Acute pericarditis will cause a small pericardial effusion. One fun thing that you should know, that all people should know, is that the slower the onset of a pericardial effusion, the more likely it is that you will survive it. If it's fast, that basically means you're strangling your heart very quickly. You don't want to do that. But if it's slow, your heart can adapt, and the sac can stretch. So it's much more likely that you'll live through that. By echo, what is considered a moderate pericardial effusion? All right, well, if 50 to 100 milliliters is small, and that is less than 10 millimeters, then probably 10 to 20. It is 10 to 20. So if you're looking at the echo picture and you have 10 to 20 millimeters, the pericardial sac, it's going to be moderate. How much fluid is considered a large pericardial effusion? Okay, so 50 to 100 milliliters is small. I'm thinking 100 to 150 is probably moderate. That's usually how they go. And this says that greater than 500 is an option. 100 to 5, okay, so here's our options. Less than 50 milliliters, which is not the case. 50 to 100 is small. 100 to 500, and then 50 greater than 500. So I think moderate's probably going to be 100 to 500. if I had to guess. And then greater than 500 is going to be a large. So let's take a look. And that's right. It's going to be greater than 500. All right. Rapid accumulating pericardial effusion may be caused by blunt trauma, ascending aortic dissection, or acute MI with rupture. I believe all of those are correct. Blunt trauma, like a car accident, can bruise you up and can cause bleeding inside the pericardial sac, which puts pressure because your heart it's trapped inside the sac. It puts pressure on your heart. Aortic dissection. I mean, the aorta is outside of the pericardium, though, so I don't know if that's right. Acute MI with rupture is true. I think maybe that aortic dissection makes this false. Let's take a look. The question is, rapid accumulating pericardial effusion may be caused by, and then it lists blunt trauma, blunt cardiac injury, aortic dissection, okay, dissection, there's a C in there, dissection, that is in there as well, and perforations in there. Acute MI with rupture, also in there, okay. So the aortic dissection can cause rapid pericardial effusion. So that is true. Your patient is 4 weeks post myocardial infarction with fever, chest pain, dyspnea, and pericardial effusion. What is the most likely the diagnosis? Probably Dressler syndrome. We've got Dressler syndrome, heart failure, ischemic CMO, which is cardiomyopathy, and then ischemic mitral regurgitation. The regurgitation is not enough. The ischemic myocardial, the ischemic cardiomyopathy is not it. I think it's Dressler syndrome because we've got a fever. It's post-MI, which you can have Dressler syndrome post-MI up to like a couple of years, I think. Chest pain, dyspnea, and a pericardial effusion. So the pericardial effusion isn't like guaranteed in regurgitation, cardiomyopathy, or heart failure. I don't know if it's guaranteed in Dressler's either, but let's see. It's usually asymptomatic. Interesting. Oh, the small ones are asymptomatic. I'm pretty confident. It's Dressler syndrome, just because it says post-MI. Because usually, if something's going to go wrong like that and cause those kinds of symptoms, it's going to be that. I can't remember if I mentioned this or not. This right here, this is a matcha latte with gluten-free oat milk, because I am made of paper and everything will kill me. Not this though. It is delicious and good for you. Let's see. Which of the following is a symptom of pericardial effusion? Chest pain, shortness of breath, often asymptomatic and found incidentally. Okay, this is just pericardial effusion in general. Often due to compression of the heart, stomach, lungs, or phrenic nerve, or all of the above. This looks like an all of the above situation because I can already tell there's two in there that are accurate. Chest pain, shortness of breath. Yep. Which is actually now, people say shortness of air because the shorthand SOB can be misinterpreted by people who are not in healthcare and people who are in healthcare. So they're trying to migrate to SOA, shortness of air, rather than SOB, shortness of breath. But I still say shortness of breath pretty often, so it'll be both. It's the same thing. So, which of the following symptom of pericardial effusion, chest pain, shortness of breath, symptomatic, asymptomatic, found incidentally? That's on here as well. Due to compression of the heart. Yep, okay, all the above. All right, we only got like 8,000 of these to go. Which of the following apply to blunt cardiac injury? Clinical presentation varies, often difficult to diagnose, usually associated with other thoracic injuries. Thoracic? I've been wondering this all quarter.
Thoracic.
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 Okay, thoracic. I've been saying it wrong all quarter. That's how you know somebody's a reader, not a talker. Okay. Thoracic. Thoracic. Okay, so we've got presentation varies, difficult to diagnose, usually associated with other thoracic injuries. I bet clinical presentation varies. I bet that's true. Let's see. Blunt chest trauma can cause structural damage to a cardiac structure, such as a chamber, valve, coronary artery, or a disruption of the aorta. Blunt cardiac injury, BCI, results from the sustained blunt trauma to the heart that is often difficult to diagnose. Check. Its clinical presentation ranges from silent to asymptomatic. CP, transient arrhythmia, shock, or deadly rupture of a cardiac wall. BCI is often part of a multi-system trauma and is usually associated with other thoracic injuries such as rib or sternal fracture, pneumothorax, pulmonary contusions, hemothorax. When these injuries are present, BCI must be ruled out. Early diagnosis is critical. Okay. So all of the above. Clinical presentation varies, difficult to diagnose, associated with other thoracic injuries. Most common BCI is a non-penetrating chest injury related to high-speed motor vehicle accidents. That sounds true to me. Let's take a look. Yep. It's the first thing in the next paragraph. Great. Right atrium and right ventricle are the most anterior chambers and account for the majority of BCI. The right atrium and the right ventricle are the most anterior chambers. That is true, and account for the majority of BCI. That would make sense too, because it's right out in front there. Yeah, most people don't realize your heart isn't like straight on. It's not like a, you can't see what I'm doing. Here. There we go. We'll just put this right here. Okay, so let's say here's my chest. We'll say my heart is right here. Okay. So most people think your heart, you got your right chamber and your left chambers, right? Like this. It's actually more like this. It's like slanted. So you've got your atria are above. They are above the ventricles, but they're also kind of behind the ventricles. And they're attached to all the tubing. Like the ventricles are just the bottom chambers that squeeze. It propels, right? But the atria kind of, gravity does most of the work with them. You've got the atrial kick where it squeezes the rest of the fluid into the ventricle, but that's not supposed to be the majority of how you get your volume of blood into the ventricles. But the point is, because it's sort of tilted back and kind of to the side, that means that your right atria and your right ventricle are going to be what gets hit when you get hit by anything, because it's right out there in front. So it would, I'm going to say true, even though I haven't found it in the text, because I mean, it's true. I'm sure that it is. All right, myocardial contusion is probably the most common yet innocuous form of BCI. Myocardial contusion, bruising of the heart. That is true. Yep. And the answer to our previous question is right above it, and that is true as well. What is the best view to differentiate pericardial effusion from pleural effusion? I'm going to say that's plaques, because you can see if the descending aorta is closer to or further away from the myocardium. So if it's inside of the descending aorta in plaques, that's going to be pericardial, and if it's outside, it's going to be pleural. Pleural is with your lungs. If you've got fluid in your lungs, that's a pleural effusion. If you've got fluid in the sac around the heart, that's pericardial. Cardio as in heart, right? So I'm thinking plaques. Let's take a look what our book says. Oof. Severe abdominal compression can cause rapid increase of heart blood flow, usually via IVC, and sudden increase resultant chamber rupture. Rare but fatal. Blunt injury is rare but usually occurs in conjunction with severe myocardial contusions. Let's take a look at our next page. Oh yeah! Oh, and it's got a picture of what I was just talking about, so you have something to associate it with. So, here, let me see if I can do this easily. So here's your heart right here. This is your left atrium. This is your left ventricle. And this is your aorta. So blood comes to here from your lungs and then goes in here and then gets pushed out here. Okay. Now right here is the space around your heart between your heart and the pericardial sac, which protects your heart from various things. It's like a little handbag that you carry your heart around in. So if the fluid is right here in front of your descending aorta, which you can see right there, it's pericardial. And if it's here, it's pleural. This is your lungs. Glad I could show you a picture. I don't know if that helps at all, but that's what I was talking about. All right. Statement that best identifies the pleural effusion. Does not change with respiration. Moves with the heart. Posterior to the descending aorta or small in size. Pleural effusion does change with respiration because it is in the lungs. Oh, I don't like that. It's too bright. Does change with respiration. Here we go. That's back on my books. I don't think it moves with the heart. I'm pretty sure it's posterior to descending aorta. It's not necessarily small. So I'm going to say C. Effusion. Change with respiration. Yep. How is pericardial fat recognized by echo? Looks kind of sparkly, kind of Edward Cullen-esque. And it is in the space between the endocardium and the myocardium. Moves with the heart, posterior to the descending aorta, or varies with respiration. It moves with the heart. I know that. I don't think it's between the endo and the myo because that's inside the heart. So it's like in the chamber. Epicardial fat is a measure of visceral fat and has been linked to an increased risk of CAD. There we go. Metabolic syndrome and insulin resistance. Best visualized on the right ventricular free wall. I know how to words. Usually from the lax or sub echo-free space between the outer wall of the myocardium and the visceral layer of the pericardium. Appears brighter or more gelatinous than the myocardium and moves with the heart. That's what we wanted. By echo, epicardial fat is brighter and more gelatinous than the myocardium and is best visualized on the posterior wall as an echo-free space. Yes. Your patient presents with a pericardial effusion. What is needed to complete a diagnostic echo? Acquire multiple windows, document the size and distribution of fluid, and mode the right ventricular free wall. Definitely all of the above. You want to get at least 2 views that line up with what you're thinking it is. Because if you just have the one, it might be wrong. But if you have 2, you're probably right. Pericardial effusion frequently originates near the left atrium. I don't think that's right. I think it frequently originates near the left ventricle, but maybe. Let's check it out. Frequently originates near the right atrium. Huh. Because it has the lowest pressure of the 4 chambers, the other chambers tend to squeeze the effusion to the area of least resistance. Oh, that makes sense. So you're, think of it as like a four-chambered, 4 balloons that are kind of connected together with a twisty, right? And the left ventricle has the highest pressure. It's like blown up the most. So if anything's gonna squeeze stuff out, it's gonna be that, because it's already full, right? And the right atrium has the least amount in it. That makes sense. Which of the following is associated with loculated pericardial effusion? Connective tissue disorder, long-standing pleural effusion, post-op cardiac surgery, or metastatic disease, or all of the above. Associated with locular. So that's I think that's just like, I'm gonna move this out of the way here. I have a lot of yarn. We're just gonna move this over here because it's taking up a lot of space. That I could move this over so I'm not leaning over into the microphone. Sorry about the noise. And also the vocal stimming. Okay. Is it vocal if it's mouth noises? Which of the following is associated? Blah blah blah. Okay. We've got lots of pictures here of sub-4, sub-sac, circumferential pericardial effusions and pericardial effusions at the right atrium. Okay. I'd like to get some pictures of this stuff for you, but I don't. I don't feel like it'll be worth it to go look that stuff up for 3 seconds unless somebody asks me to. So if someone would like to see it, just let me know. Okay. Oh, that's tamponade. I think the loculated stuff is actually earlier in the chapter. Spiral bound books coming apart. I've been turning the pages too much. All that learning. Okay. Loculated. Effusion, blunt. Maybe not. Okay, I don't see a section just on that, so I'm going to read the next paragraph after the question that we went through before. Loculated effusion. Oh, well, here we go. Loculated effusion is more common post-cardiac surgery or metastatic disease. Okay, so that's going to be C. Let's make sure there's none of the other two in there. Exudative pericardial effusion may contain fibrin strands. Okay, well that's the only thing that's mentioned, so I'm thinking it's going to be post-op cardiac surgery or metastatic disease. Circumferential pericardial effusion is best visualized from the suprasternal window. I think that's going to be true. That's not just one view, that's a couple. So let's see. I don't know, because it has actually 3 different ones, and you can get it through your subcostal views too. So it's asking if the best visualization is the suprasternal. I think that's going to be false. I think the subcostal and sacs would probably both be the best. I mean, but you can see it in plaques too. I need to find the answer for that one because I'm not sure, and I want to be sure. Pericardial effusion originates near the right atrium because it has the lowest pressure of the 4 chambers. The other chambers tend to squeeze the effusion to the area of least resistance. It's unusual for an effusion to be positioned solely anterior unless it is loculated. Loculated effusion is more common post-cardiac surgery or in metastatic disease. Exudative pericardial effusion may contain fibrin strands, adhesions, or uneven distribution. The fibrin strands are frequently present with a long-standing effusion when associated with metastatic disease. I think the 4-chamber in the loculated is going to be really good, but peristernal, lax and sacs, and sub provide excellent visualization for circumferential effusion. And the question says that suprasternal is the best. So I'm going to say false. Because you want to get below it. And I don't think you can do that from a suprasternal position. Okay. Fibrin strands. Yeah, we got them. We got fibrin strands. And it looks like something straight out of a horror film. I'm leaning to the left a lot, so I'm just going to take you with me. Let's see. How's that? Okay, just making sure. Yeah, fibrin strands. Tamponade is a life-threatening accumulation within the pericardial space without hemodynamic compromise. That is incorrect because there is a hemodynamic compromise. To be specific, let's see where the definition is. The definition is gross, so I'm sorry. Tamponade, potentially life-threatening accumulation of fluid, blood, clots, pus, or gas within the pericardial space that has a significant hemodynamic compromise on the cardiac filling and function. What happens when excessive pericardial fluid accumulates in a non-compliant space? Compresses the heart, improves diastolic filling, improves preload, increases cardiac output. It compresses the heart. It does the opposite of all of those other things. It's bad. It's very bad. Tamponade causes elevation and equalization of systolic and pericardial pressures. I don't know if that's true. Because it doesn't specify what kind of tamponade. All tamponade. All right, let's just read this list. I think that sounds good. We'll just read the list. Oh, that's so good. Acute onset versus chronic condition, mild to severe accumulation, circumferential versus logulated distribution, excessive accumulation in a non-compliant pericardial space between the parietal and visceral layers of the pericardium that compresses the heart and limits cardiac filling. Impaired diastolic filling progressively worsens. Elevation and equalization of diastolic and pericardial pressures. That's what I thought. Not systolic, a diastolic. Because systolic is going to be squeezing, but the diastolic, when everything's supposed to relax, is going to be more susceptible to the compression from the outside. Elevation and equalization of diastolic and pericardial pressures, reduced cardiac output, insufficient preload that cannot sustain cardiac filling results in a dramatic decrease in coronary and systemic perfusion. That is a fancy way of saying your cells cannot get enough oxygen because there's not enough blood carrying the oxygen. Sort of like if you need 100 boxes of cereal a month. It seems, I don't eat cereal, so I don't know. Okay, so if you need 100 boxes of, that seems so high. We'll say 100 boxes of cereal a year. Whatever. And the trucks are supposed to bring you one per month. You need 12 per year, and you need one per month. But because of restrictions at the factory, they can't get certain supplies in because they have a staffing reduction. There's like a strike or something. So these trucks aren't bringing all of the cereal. So you end up getting, we'll say, one box of cereal every 2 months or one box of cereal every 3 months. Now, you can't, in this scenario, get cereal anywhere else. In fact, you can't get any food anywhere else. And also, nobody's picking up your garbage. So you are going to go septic because you have neither oxygen nor toxin removal from the cells in your body. And that is what perfusion is referring to. Perfusion. For future reference. All right, where are we? Insufficient preload that cannot sustain cardiac filling results in dramatic decrease in coronary and systemic perfusion. So your heart's not getting enough oxygen either. All right. And cardiac arrest and death. All right, we've read that list. I'm going to take a look and see if we have any questions about anything we just read. Low pressure tamponade has been diagnosed in patients with intravascular fluid depletion. Well, that wasn't on our list, but I'm sure it's here. Low pressure tamponade is the first words in the next paragraph, so we'll just read that too. Low pressure tamponade is isolated but possible due to low pericardial pressure that results in compression of the chambers because of low filling pressure. It has been diagnosed in patients with intravascular fluid depletion. So that is the truth. Regional tamponade usually impacts the right heart due to the loculated effusion or precordial blood clot post-cardiac surgery. Oh, jeez. I'm going to read that sentence again. Oh my God. This page bigger because we're about to be going to it. Beep boop, beep boop. Okay. Regional tamponade. This is probably the next sentence. Regional tamponade affects selected chambers, usually the left heart. Oh, so it's already a false. Let's read this so it's in our brains. Regional tamponade affects selected chambers, usually the left heart, due to a loculated effusion or precordial blood clot, post-cardiac surgery, or MI. Okay. I will attempt to remember that. Commit it to the memory. Okay. Oh yeah. We gonna stretch. How long have we been doing this? How much we got left on this section? We're only like halfway through. This is going very slow. Oh, well, we're about 3/5 through. Okay. Tamponade is a clinical diagnosis. What does echo determine? Okay, let's take a look at our options. What's our context here? Hemodynamic effect, location of the accumulation, size of the accumulation, or all of the above. That's definitely going to be all of the above. Let's double check that though, so we make sure to get it right. Oh, tamponade is clinical diagnosis. Oh, and important. I'm not going to be able to diagnose. What I'm going to be doing is finding all of the information that the cardiologist needs in order to make a diagnosis. Which means if I don't give them all of the information, they won't be able to make the right choice. So it's important to know what I'm looking at so I can give it to them. All right, but yes, we don't do diagnoses. We just get information. It is important to remember that tamponade is a clinical diagnosis. Echo determines size and location of accumulation, presence, and degree of hemodynamic compromise on a cardiac filling and function. Yorp. All of the above. Which of the following is a component of Beck's triad? Decreased venous pressure, hypertension, muffled heart sounds, or all of the above? Well, you can't have decreased venous pressure. Okay. All right, there's some stuff in here that I think I know the answer to it. Hypotension and a weak pulse due to low cardiac output. So already not the hypertension. I think it's decreased venous pressure. I think it's that. We'll find out. Muffled heart sounds. Shit. Immediately wrong. All right. Well, it's probably increased venous pressure then because of the pressure. A derp. Muffled heart sounds and elevated venous pressure. Oh, that's right. The jugular vein. So if you see somebody who's got tamponade, there's a vein that goes up through here and it dumps into the superior vena cava, which dumps into the right atrium. And if you've got increased pressure, that whenever that's supposed to dump and it doesn't, it like puffs up. Like you basically, like, you can see a vein the size of my finger filling with blood that's being dumped from the brain down in through there where it's supposed to be getting in the heart, but there's no room. It's backed up. All right. So if you see anybody who's got that going on, if they haven't been to the cardiologist, they should go. They should go. Even if it's not this specifically, that's a very serious symptom that needs to be addressed. Okay. Oh, let's not go backwards. Let's go forward. Here we go. Oh, pulsus paradoxus is an exaggerated decrease in the diastolic pressure with inspiration. I think that is true. Pulsus paradoxus. Where are you? Pericardiocentesis, which is sucking the fluid out of there. Sorry about the mouth sound. That was unpleasant, I think, probably. Maybe it's on the other page. Oh, it is. Yeah. And yes, it is an exaggerated decrease in pressure because your pressure is supposed to go up when you breathe in. How does the sonographer assist during pericardiocentesis? Locate the effusion, monitor the size of the effusion, lay out the sterile field, all of the above. There's a lot of stuff nurses do that we are there for, but we are not responsible for. Oh, I misread that. It says stay out of the sterile field, not lay out the sterile field. Yeah, you should definitely stay out of the sterile field. I think it's probably going to be all of the above. Let's take a look at our lists here. Causes, complications, treatments. Oh, here we go. Pericardiocentesis, the sonographer plays an important role. Determine the size and location of the pericardial effusion, or, prior to the tap. Once the patient is prepped, use extreme caution to stay out of the sterile field. Echo guidance is helpful. However, visualization of the catheter within the pericardial effusion may be difficult. A quick bubble study can verify catheter location. All of the above. Bubble study can verify the catheter location, pericardial effusion during pericardiocentesis. Yes, that is what we just read. Potential treatment options for tamponade include pericardial window or periectomy. That is true. Pericardial window is when you cut a little this out of the thing. It's a flap. It's a flap that just opens up and then they drain it. Patients with muffled heart sounds, pulsus paradoxus, tachycardia, and dyspnea. Tamponade is suspected. What might echo find? Dilated inferior vena cava with diminished inspiratory collapse? Probably. Pericardial effusion? Probably. Right atrial and ventricular diastolic collapse? Probably. All of the above. Let's see here. Our list of complications, signs, and symptoms. Patient usually feels horrible and needs to sit up. Yeah, if they lay down, their heart can't do anything because gravity does a lot of the work for the atria, like I said earlier. So patients with tamponade can't really do that easily, to put it very conservatively. Depends on etiology and rate of accumulation. Dyspnea improves when sitting up. Fever, chest pain, cough, lethargy, palpitations, light headedness, dizziness, syncope, altered mental status, anxiety, dysphagia, blue appearance of lips and skin, cold extremities, peripheral cyanosis, which is blue fingers and toes, hypotension, tachycardia, symptoms related to underlying cause, cardiogenic shock, and death. Tamponade increases in severity. The right ventricular diastolic collapse remains throughout the respiratory cycle, and the longer the collapse, the more severe the tamponade. That sounds like the opposite of true. Let's see. Right ventricular diastolic collapse. Let's see. There it is. Oh, here. Pictures for you. So these two illustrations are two views of the heart. The one on the top is a subcostal view. So they put the transducer kind of around your stomach area, kind of up top of your stomach, and they press down and they look at your heart from below. And the other one is a P-sax, which is on the left side of your chest. It's sort of getting like if you put your heart up and down, it kind of chops it in the middle. So you get like a circle. Anyway, all that black stuff is fluid that you have to get out because it doesn't belong there. It belongs in your veins. Doing blood work that blood does. All right, what was our question? Right ventricular diastole when the ventricles are filling. Early on, right ventricular diastolic collapse is present during inspiration, reflecting a transient increase in pericardial pressure that exceeds right ventricular pressure. As the tamponade increases in severity, the collapse remains throughout the respiratory cycle. The longer the collapse, the more severe the tamponade. Compare the right ventricular wall motion to the mitral valve and the tricuspid valve motion. Diastolic collapse occurs when they are open. Okay, so it sounds like our thing is actually true, not false. As tamponade increases in severity, the right ventricular diastolic collapse remains throughout the respiratory cycle, and the longer the collapse, the more severe it is. Yeah, so that's true. Paradoxical septal motion means the ventricular walls move parallel to one another. I think that means that the septum leans in to the left side instead of leaning into the right side if it leans in at all. Walls move parallel to one another rather than their normal contraction toward and relaxation away. Yep. It explained it in a different way than I was familiar with. But that's good. I like all the angles. Respiratory variation is detected when left ventricular diastolic dimension blink with inspiration and the right ventricular diastolic dimension blink with inspiration. I want to say increases and decreases. Let's see. I'm wrong. Respiratory variation of ventricular chamber size. Left ventricular diastolic dimension decreases with inspiration. Right ventricular diastolic dimension increases with inspiration. Okay. B. You detect a moderate to severe pericardial effusion and a swinging heart. What is an excellent method to rule out right ventricular diastolic collapse? I'm sure they have a specific thing they want me to do. Oof. Dilated hepatic vein. Oof. Oof. All right, swing it around. M mode. That's a good idea. Obviously. That's what you're supposed to do. Makes sense that it's a good idea. The right ventricular diastolic collapse. Right ventricular free wall collapse into the right ventricular chamber during diastole, while the mitral valve and tricuspid valve are open. Parasternal, lax, sacs, and sub 4 chamber sacs views are ideal. Place M mode cursor through the pericardial effusion, right ventricular free wall, and mitral valve. Place the M mode cursor through the pericardial effusion. Excuse me. Increase sweep speed to more than 100 millimeters per second. Oh, I guess that is fast. That's what we usually have it on anyway. Compare right ventricular free wall motion to mitral valve motion. Okay. M mode. Which of the following methods will help evaluate the mitral and tricuspid inflow respiratory variation? Probably the next page. Mitral inflow E wave velocity decreases significantly with inspiration. A drop of greater than 25% is consistent with tamponade. Physiology. Tricuspid inflow E wave velocity decreases significantly with expiration. A drop of greater than 40% is consistent with tamponade. Physiology. So mitral valve E wave. And real quick, E wave. So I'll just show you. This is probably not going to mean too much, but this right here, that means a lot. Okay, so when you pulse wave, you get a sample gate. I'm not going to explain all of that. Okay, so the blood moves. This tracks how fast it's moving. And those waves are tracking the speed. It's tracking the velocity, right? But just to keep it super simple, if it's going wah, wah, then those are going to be like up here when that happens. And if they're like if you have obstruction with your aorta, it's going to go, because as the pressure decreases, those valves are going to close a little bit. The velocity is going to go down. Okay, you know what? I can't think of a way to explain this without context, because I have no idea how much people know. Basically, those waves show you the movement of the blood in the heart. The E waves are for they're for passive filling. So like when your mitral valve and your tricuspid valve open, the E wave is the velocity of the blood dumping in there without any contraction. The contraction is your A wave. So when you track the E waves, because the tamponade is pressing in on the entire heart, equalizing the pressure during diastole, which is when that blood dumps in. Because of that, you're going to see some crazy stuff during that. You're going to see stuff like this. Now, I don't know everything, but I hope that that explained what we're looking at least, in a way that was accessible. Sorry. Let's see. Okay, so our E-wave velocity decreases significantly with inspiration. So when you breathe in, the E-wave velocity dips. Greater than 25% is consistent. Tricuspid inflow E-wave velocity decreases significantly with expiration. So when you breathe out, the E-wave for the tricuspid flow drops greater than 40%. I feel like that's something I'm going to need to know for next quarter. Keep that in my brain. All right, so our question is, which of the following methods will help evaluate mitral and tricuspid inflow respiratory variation? We're going to use pulse wave for sure, and we're going to increase the sweep speed to 100, I think it said. Right. Was I just imagining that? What's happening here? Decrease sweep speed to 25, I'm seeing down here for okay, yeah, this is step by step. So respiratory variation is seen in a wave-like motion across the top of the mitral and the tricuspid inflow Doppler waveforms. So you place the pulse wave Doppler gate at the tips of the mitral and the tricuspid valve leaflets. Decrease the sweep speed to 25 millimeters a second to compress and capture more waveforms. If the heart is swinging, watch a few cycles to make sure the Doppler waveforms are stable. It may be helpful to label the display inspiration and expiration. If the heart is swinging, that is going to be a skill that I would like to learn how to have. That sounds very difficult. But I will say that certain views come in and out with breath anyway. And I've gotten to the point where I can put the pulse wave in the place where it's supposed to be. And if I hold very steady and I know where it's going to go, like if I watch for a few breaths, I can keep it there and I can get the waveforms that I need to see. So I feel like with a swinging heart, I can also develop the skills to be able to do that too. It's not going to be easy, but it's going to be worth it. So, all right. Which of the following methods help you evaluate? Okay. Decrease the sweep speed to 25. Measure IVC dimension during diastole and systole. Place the continuous wave cursor at the tips of the leaflets. It looks like it's just the sweep speed because it's the IVC isn't mentioned here for evaluating the mitral and the tricuspid valves, and the continuous wave isn't mentioned either. So we're doing pulse wave for this. So we got A. We're almost done. Only got 15 questions left. Oh, no, we don't either. We've only got 6. Nice. Okay. Choose the statement that supports respiratory variation seen within tamponade. Mitral inflow E waves of velocity decreases with inspiration greater than 25. That's true. Tricuspid greater than 40 with expiration. Yep. Wave-like motion across the Doppler waveforms. All of the above. All right. Now, the last 5 questions, it looks like, are identifying things on diagrams here, but there's only 5 of them. All right, 41, decrease your sweep speed. That's B. That's going to be with the pulse wave Doppler. Increase your sweep speed is going to be on A to 100. Okay, yeah. Paradoxical septal motion. I think that's going to be A. I wanted to get more done today, I think. I think I probably will. It's only 7 o'clock. I'm so tired, though. I did not sleep well last night. I was so very awake. It was okay, though. Like, I was still relaxing, you know. I think the paradoxical septal motion is going to be A, which is in this graph right here. But I haven't seen anything that says that. Oh, there it is. Yes, it's, there we go. Paradoxical septal motion is A. M mode. Respiratory variation is going to be in 44 in B. Diastolic collapse of the right ventricle is going to be, I think, in A, because we can see it in the M mode there. Yep. Awesome. Okay, cool. So looks like all we have left to do is this thing that's been up on the screen forever that we haven't done yet. I'm really hoping I don't have to relog in. I don't. Awesome. All right. Choose the statement that best describes pericardial effusion. Abnormal amount or type of fluid around the heart between the parietal and visceral layers and circumferential versus loculated. Pericardial effusion can be described as acute versus chronic and local versus systemic. True. Which of the following would most likely cause a small pericardial effusion? Let's see if I can remember it without looking at my thing. I'm going to say acute pericarditis. I am correct. Great. By echo, what is considered a moderate pericardial effusion? A moderate is going to be... Okay, so less than 10 is little one. I'm thinking it's 10 to 20. Yep, 10 to 20. How much fluid is considered large? Greater than 500? Yep. Rapid accumulation of pericardial effusion may be caused by blunt trauma, ascending aortic dissection, or acute MI with rupture. And that is going to be true. And it looks like there is something that I did not pay attention to before, and that was ascending aortic dissection. That is important. Your patient is 4 weeks post-MI Dressler's. Which of the following is a symptom of pericardial effusion? Chest pain, shortness of breath, often due to compression of the heart, asymptomatic and found incidentally. I think that's going to be all of the above. Which of the following applies to blunt cardiac injury, BCI? Clinical presentation varies, often difficult to diagnose, usually associated with other thoracic injuries. I think that's going to be all of the above. Most common cause of BCI is a non-penetrating chest injury related to a high-speed motor vehicle accident. I think that's going to be true. Right atrium and right ventricle are most anterior chambers and account for the majority of BCI. True. Myocardial contusion is probably the most common yet innocuous form of BCI. And that is also true. Severe abdominal compression, blunt coronary artery injury, valve injury, and blunt pericardial rupture are rare but very serious types of BCI. Also true. Is that all true? Are they all? I mean, we went through it, so I'm going to trust myself. What is the best view to differentiate pericardial effusion from pleural effusion? And that is going to be blanks. Choose a statement that best identifies pleural effusion. Pleural, posterior. I was like, why did I click that? And it's because it's behind the aorta. How is epicardial fat recognized? It moves with the heart. Right? Okay. By echo, epicardial fat is brighter and more gelatinous than the myocardium and is best visualized on the posterior wall as well as the echo-free space. True. Your patient presents pericardial effusion. What is needed to complete the diagnostic? Echo, all of these things. Pericardial effusion frequently originates near the left atrium. I think that was false because it was the right because of the low pressure. I wrote true. I'm gonna go back and take a look at this because I feel like it's false from what we read. I think I might have circled the wrong one. Non-penetrating. Best views. Peristernal. Pericardial effusion frequently originates near the right atrium. Yeah, so that's false. I just, I circled the wrong one accidentally. Look, we're learning. Okay. Now, if that one is actually true and I have to go back in here and change that later, I'm going to be a little grumpy. Okay, here we are. Where are we at here? Number 20. Okay. Which of the following is associated with loculated pericardial effusion? I've got post-op cardiac surgery and metastatic disease. Circumferential pericardial effusion is best visualized from the SSN. Oh, my dumb butt. Oh my God. That is obviously false. The suprasternal notch, which is the only way that I feel like I have ever thought about it, is right here. Like like your collarbone. Let me see if I can put my collarbone up a little bit. So it goes down like this, and then right here. So you put the transducer pointed like down, like this direction, and you look at the heart from above. That's a suprasternal notch. That you're not going to see an effusion from there. Dumb. Oh, what did they say that it was? They said suprasternal window, not the suprasternal notch. Okay, that's fine. Fibrin strands are frequently present with long-standing pericardial effusion. Yes. Tamponade is the life-threatening accumulation within the pericardial space without hemodynamic compromise. False. What happens when an excessive pericardial fluid accumulates in non-compliant space? Compresses the heart? Yep. Tamponade causes elevation and equalization of systolic. Nope, it's diastolic. Low pressure tamponade has been diagnosed in patients with intravascular fluid depletion. True. Regional tamponade usually impacts the right heart due to loculated effusion or precordial blood clot post-cardiac surgery. That is false. What makes that false? It's probably just left heart. It's probably the difference. Usually they're pretty simple like that. Tamponade is a clinical diagnosis. What does echo determine? Hemodynamic effect, location of pericardial effusion, size of accumulation. Yes, all of the above. And our muffled heart sounds, because we got hypotension and increased venous pressure. Pulsus paradoxus has an exaggerated decrease in diastolic blood pressure with inspiration. True. How does the sonographer How does the sonographer assist during a pericardial centesis? Locate the effusion, monitor the size, stay out of the field. All of the above. Bubble study can verify catheter location within the pericardial effusion during the pericardial centesis. Potential treatment options for tamponade include pericardial window or pericardiectomy. True. The patient presents with muffled heart sounds, pulsus paradoxus, tachycardia, dyspnea. Tamponade is suspected. What might echo find? I think that one was all of the above too. Dilated IVC with diminished inspiration collapse, pericardial effusion, RA and RV, diastolic collapse. As tamponade increases in severity, the right ventricular diastolic collapse remains throughout the respiratory cycle. The longer the collapse, the more severe the tamponade. That we determined was true. Paradoxical septal motion means the ventricular walls move parallel to one another. Respiratory variation is detected when the left ventricular diastolic dimension decreases with inspiration and the right ventricular diastolic dimension increases with inspiration. You detect a moderate to severe pericardial effusion and a swinging heart. What is an excellent method to rule out the right ventricular diastolic collapse? That would be M mode at the level of the pericardial effusion with right ventricular free wall and mitral valve. Eyeball it. Yeah, that sounds like the best option. Which of the following methods will help evaluate the mitral and tricuspid inflow respiratory variation? Oh, decrease the pulse wave sweep speed to 25 millimeters per second. I think that's it. Yeah, we're not doing anything with this. Choose the best statement that supports respiratory variation seen with tamponade. Mitral inflow decreases with inspiration greater than 25. Tricuspid decreases with inspiration greater than 40. Wave-like motion across the Doppler waveforms. All of the above. Right? Pretty sure. Yes. Okie dokie. Okay, so we've got M mode and we've got pulse wave. So right ventricular diastolic collapse we're going to see in M mode. So that's going to be A. Right? Oh, these are in different order. Okay, well, cool. Oh, give me the practice. Paradoxical septal motion. I think that's also going to be A. Yep. Increased sweep speed. That is going to be B. Respiratory variation is B. Decreased sweep speed is also a B. Oh, no, resume. What didn't I do? I didn't do this one. Oh, I'm so glad that it warns you. What do you get? 100? 100? Ah, biscuits. What do we get wrong? Oh, it's echo free. If it's brighter and more gelatinous, also echo. Yeah, okay. All right, well, that makes sense. Is that the only one we got wrong? That's a weird question, if I'm being honest. False. Pulsus paradoxus, also false. I must have read it weird. I think I might be tired. I'll go back through and review that. So, okay. Cool. Too many retakes? I'm not retaking it. I'm just going back. Thank you. Cool. That's fine. Okay. Well, we got that done. Whoever is here, good for you being here. This is not one of those that I can actually keep up because of the nature of what I am doing, which is homework, like legit homework. So good for you showing up, hanging out. Wait, that's not a thing I can do anymore. The OK symbol has been taken over by bad people. So we're going to do this. Heart you. All right, so are we gonna, how long have we been doing this? Hour and a half? Do I want to take a break? Oh yeah, I got grapes. I washed these an hour ago. Okay. Let's see. My music turned off. Let's see what I can do about that. Cool. Okay, so now the question is, what am I doing? Do I need to get up, move around? Probably. How much everybody get up? Everybody get up and stretch. Okay. Just want to eat my grapes. Check out these fish. We got so many coins. You know, it's funny. I like playing this, but we did not focus in this game specifically. We didn't choose the focus at all. We drank our little drink, but I got so distracted by the fact that I could not mix the drink. Like it doesn't exist. Let's just drink a whole glass of lime juice. Is that available? That's available for some reason. Triple lime juice for Razor Bright Citrus Blast. Refreshing and alcohol free. Alright. Cool. We'll put our little timer on for a couple of minutes since we did the thing. We did the thing. It counts. I like her outfit. She's got freckles in this set. Very cute. I got an axolotl. Also very cute. Oh, brain break. Okay, so let me see what I have to do on my list. Oh, I did that. I did that. I did that. Cool. This is good. Knocking stuff out I didn't even put on the list. I'm waiting for a couple of things to be updated in the grading system. It's very frustrating, but I get it. Like, there's two people who need to go through all of them. And these protocols, some people took 3.5 hours to do them. We were supposed to take an hour and 20 minutes, which is bonkers to me. That is too short. That is not enough time. But the thing is, because technology has gotten better, you don't have to do certain things that you used to have to do when you did echo. So you don't have to like manually upload things. It basically uploads it like to the cloud. So you don't have to manually do that stuff. But that also means that you can be with patients for more time in a day. Now, you would think that as technology gets better, the pressure put on the humans would get less, because we would be able to, like enjoy those advancements, and take care of ourselves better as technology gets better. But instead, sonographers are supposed to take on more patients, which causes repetitive stress disorders in higher numbers than we've ever seen before. So you have to get through these scans in half an hour to 45 minutes, get on to the next patient, and you don't really have any breaks in between at certain points in your day, depending on what you're doing, where you work, what kind of echoes you're doing, all that good stuff. But as a new person doing it, learning how to do it, an hour and 20 minutes for a complete protocol, which is about 120 pictures. And when I say pictures, I mean you have to find it in the chest without being able to see it. You have to, have that spatial intelligence in order to get that, and the education of landmarks in order to find it. Sometimes it takes a while. Especially since the things that you're trying to find are always moving. It takes a lot of stamina to have to do that, but I feel like I'm getting better at it, What I want to specialize in is like emergency and on call anyway. I don't want to do the 9 to 5 stuff. I want to be available when people need something the most, you know? And like the 9 to 5 people, they do good work. They are extremely important. And without them, people would suffer. You know, they're super important. For me, I like being awake late at night. I like, I can be on call. I can be that person. And I know a lot of the people who want the 9 to 5, they want to wake up with the sun and go to sleep when the sun goes down. Those people, they work best with the 9 to 5 thing. I want them in those places. Me, who's best at night, I can do on-call stuff. No? I want to be available when people need me, you know? And I think I would be best used in that context. So, hopefully that also means that I will have breaks in between scans. Because I'm not 22 anymore. I don't have the physical stamina to be doing that kind of shit. It would be a very short career for me if I'm having to do 12 scans in a day. No, thank you. But I'm sure I'll find a spot that fits good. Still not updated. That's unfortunate. Okay, well, I can see what I need to do at least. These grapes are freaking awesome. Tamponade video quiz. I cannot do that with you guys. Got everything done for that class. Got everything done for hemodynamics. I do have more to do for Echo Lab. I can do some of that with you. I can update my protocol. Yeah, I can do that. Okay. That's what I was planning on doing anyway, but it looks like that's the best thing for me to do. The other stuff I can do by myself. And when I say I can do it by myself, I mean I can't do it with you. These grapes are awesome. I really want to play some more Disco Elysium. That was a fun game. Maybe if I get everything done that I'm trying to get done, I will take a break and do that. Because apparently I've gotten too stressed and my heart apparently needs beta blockers in order for me to not have a tiny heart attack again. So maybe playing a video game would be good. Maybe. Yet another reason not to save this live stream to the VODs. Private health information. Okay. So, how do I want to do this? We don't need this up. Oh no. Oh, look at me. I don't want to dox myself. Hang on a second. I don't think there was anything up there that was inappropriate to have in public, but it's not guaranteed. Oh, let's see here. Oh, do need to know these. I'll just go through them verbally. Bubble study, negative contrast, left to right. Transgastric, right ventricular inflow. So that's from the bottom of the TE. Transgastric. LAX left. Oh. I can't remember what LAX stands for. I've just been saying plaques forever and sacs. Biscuits. Alright, well, transgastric plaques. Mid-esophageal, 4-chamber, mid-esophageal, 2-chamber, mid-esophageal bicaval, which looks like a little crab. Bubble study, negative contrast, sedation medications are Versed, the Fent, the Prop, amidodrin to treat AFib and ventricular arrhythmia. Antagonist reduces the normal action of a protein. Agonist mimics the normal action of a protein. So the antagonist reduces the normal action of a protein. Agonist mimics the normal action of a protein. Antagonist stops things. Agonist mimics things. Narcan reverses the effects of an overdose of things that are given to you in order for them to do surgery. Beta blockers decrease the heart rate and the blood pressure and the contractility. Vasodilators improve heart function by reducing work and lowering resistance to the heart has to pump against. Anticoagulants prevent blood clots. Lisinopril, side effects, cough. Statins treats high cholesterol. Antiplatelets, aspirin, Plavix, Effort. Propofol, drug class, sedative. Anybody my age is going to remember Propofol in a very specific context with a very famous singer. All right. Beep, boop, boop, a doop. Peer reviews, additional comments, lab papers, complete echo. Is that with the numbers? Did I change this? Crap on a stick. Oh, I bet it is complete echo fill in the blank. I got the apical fill in the blank. I don't. I bet it's in the history. View. Tools. Version history. Here we go. Okay, so I am gonna go ahead. None of those are useful to me. That's fine. This is fine. This is fine. Okay, so I'm going to go ahead and change the color of this. There we go. And that should be fine. Okay, so now I can share the screen with you. Echo. Nope. Not that. There we go. Show me. There we go. We got the docs. As in documents. I don't know why I don't just move this over here. Be easier to deal with. There we go. Okay, this should be fine now. Yay! Okay, I guess I'll zoom in. I'm gonna keep it in the pages because that's how I have to print it out, so I don't usually keep it there, but okay. Okay, so I was told no greater than 20, so I'm gonna erase this. There we go. Okay, capture and review, which I am getting a little bit faster on, which is good. Okay. And I actually want this here because we want to acquire 2. So put this little checkbox here as well. Oh no, that's not what I want. That is very soft and nice, but I do not need it touching my hand right now. Please stop that. Okay. We'll just do it this way. Can I bring it up here? Crap, I cannot. That's okay. We'll just leave it like this then. That's going to be confusing. Okie dokie. 1 of 2, 2 of 2. Zoom mitral valve left atrium. Color mitral valve left atrium. On zoom. Zoom left ventricular outflow tract and aortic valve. Color left ventricular outflow tract and aortic valve on zoom. Freeze and scroll to mid-systole. Valve open. Measure LVOT. Scroll to end diastole. AOV closed. Measure root. I know this, but I'm putting it here anyway. Inner to inner. And the ascending aorta is going to be inner to inner. The root is going to be inner to inner. Isn't it? No. Inner to inner, leading to leading, leading to leading. We'll just put lead to lead, in to in. I'll take up a little bit less space. Don't write it wrong. All right, we go to M mode. We do all the same things that we did before. But this is all one picture. Lovely. Yeah, that was needlessly confusing. I don't know why I combined them like that. Like, I mean, I think I did it because that's the way that it was on the original, but I don't need to do that. Ugh, this lady needs to know we're working. Meow. Fish, 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 fish. Yes, give me the coins. Awesome. Coins, coins, coins. Beep boop. What do you think? New dress? I don't know. I like this one so much. I don't think that there is one that looks nicer than this. I haven't tried all of them, but this is just so pretty. I don't see how any of them could be better than that one. I do like yellow though, so maybe we should try that. All right, let's try the yellow. Oh, that's pretty too. I like that. Okay, let's be yellow for a little bit. That's nice. Okay, so we know we can't do all three of them. We can do just ginger, just lime juice, time to get crunk. Can we do just dark rum? We can. Awesome. Neat dark rum in triplicate, oak, caramel, and cocoa riding a slow, powerful wave. Pow, pow, pow. Beautiful. Okay, let's set this timer a little higher because we're crazy like that. Not that high. Boom. Lovely. Okay, back to it then. Actually, because of what we have going on, I'm going to move this over here. There we go. Okay, so we got our rivet and we've got our continuous wave. You know, I think I'm gonna highlight on here too, because I was highlighting oh, I have nothing to highlight over here, I don't think. I was highlighting on the actual page, like for notes and stuff, but I feel like I could just highlight on there since I'm already doing it. continuous wave. What do we want continuous wave to be? Do you realize that I paused waiting for you to answer? I am tired. I woke up at like 7:30 this morning. And you know what I did? I read the freaking news. Oh, bad idea. Concentrate. Can't be watching that garbage. Oh. What is crazy though? This year, because I've been I'm like on it. I'm, writing letters and protesting and calling senators and, usually very, very active, trying to do things the right way or whatever. And I've been nothing but horrified and disappointed over the last 10 years, if I'm being totally honest. And it just gets worse, right? So I have to concentrate on what I'm doing right now. Otherwise, I won't be able to learn anything because my cortisol levels will just be too high. I won't actually stick anything and I'll hurt people if I don't know what I'm doing. So I've been very, very focused. Well, for obvious reasons, I found out what's going on in the news recently. And it's so wild having a break and then seeing all the things that have happened since I've been not watching intently, And I don't think that people realize how dramatically things have changed since January. Cuckoo bananas. I will say that I'm handling that live footage that went around. I'm handling that really, really well for two very important reasons. Number one, I've been in healthcare a long time. I've seen a lot of things, and I myself have been involved personally, physically, with that kind of physical trauma. Because of my experience in medicine and with my personal experience with that specific kind of injury, not that one specific, like not that, obviously. But because of that, and also because I don't believe that was something that he would have been opposed to happening to anybody else, because he's said it multiple times, like that was okay to happen. So if that's okay to happen, then good. You got to be the change you want to see in the world. You got to be it, good for you. So I'm handling it pretty well because of that. But I feel really bad for people who have, number one, not had experience with seeing traumatic injuries happen and seeing the aftermath of them. I feel really bad for those people who had to deal with that. It's rough. It's a rough thing to have to. It's like there's a part of you that changes and it never changes back. And you get to try and mold that change. You get to affect that change. You can do that, but you can't stop it. You can't stop the change. It happened as soon as you saw the thing. It happened. And I hope for the best for people. And I accept what happens regardless. And then I work with that reality, whatever that happens to be. So I foresee finishing this quarter and completely ignoring all of that for another week and a half until I'm done with finals. And then I get to deal with that again. So bonkers. So bonkers. I think the idea of the like compulsory mourning for somebody who's actively hurting people and putting terrible things out into the world is a strange concept to me. It's a very strange concept. I don't think that's what that person would have wanted anyway, because they actively said multiple times, not only that sacrifice was a good one to make, that was expected, that was the thing that was okay, but also that empathy was a disease and that it was bad to have. So I think that the idea of acting like this is anything except for exactly what he wanted to happen in the world it doesn't make any sense to me. That's the world he wanted to see. That's the world he believed existed, and it came for him. Live by the sword, right? So maybe the world will get a little less violent, since one of the people shouting for it to happen is no longer able to do that, but I doubt it. There's enough monologuing for me. Back to the task at hand. What color are we going to make this continuous wave pulse Doppler? Continuous wave Doppler, not pulse. That's a different Doppler. I want continuous wave to be yellow, but I also know that I can't see it in the lights in the lab. So we're going to make it pink. Don't care for that, but that's what we're doing. Okay, so continuous wave for the tricuspid valve, because tricuspid valve only gets continuous wave. Does not get pulse wave. So we don't care about it. I don't care about the poor little pulse waves. I want it to be purple, but it's too close to pink. Blue, I guess. Teal, like an aquamarine. That worked. Yeah, that's fine. Oh, what are we doing? There's no way 30 minutes went past. Did it? No, I got 20 left. Okay. Axolotl. Okay, so pulse wave's going to be this aqua color, because remembering to measure things, remembering to do this, so extremely important. Okay, so our measurements. For the continuous wave, we've got TRV max. Let's do a green for that. Green. And for our pulmonary valve, we'll do purple. I really wanted to go on a walk before it got too dark. That's okay. Green. Pulmonary valve, right ventricular outflow tract, main pulmonary artery. Long and tall, long and tall. Let's put over here first before we move on to that. We want our baseline up and our scale 300 below. I got a bunch of points off for where my baseline was on the last one. So we're not going to do that this time. RVOT. pulmonary valve. Pulse wave in right ventricular outflow tract. Are we at leaflet tips for this? We are. We're at the leaflets. Leaflet tips. Okay, and we wanted the pulmonary valve to be purple, but that's too close to pink. So what's our pulmonary valve going to be? Blue? Maybe we could make it like a soft blue. There we go. Okay. Yeah, that's better. We'll do those soft colors. Yeah, that's fine. I'm a lot more comfortable with that. Okay, so we want the VTI trace and the pulmonary valve accel time. Base peak. Base up 2/3 because it's below. Okay. We'll go after this. Below. Right ventricular outflow tract, VTI. Okay, so then we're going to continuous wave through the pulmonary valve, and that is 2/3 in the middle. Okay, so we're going to measure our pulmonary insufficiency and the PV max. I'm pretty sure if those are on both sides, but I'm actually going to look that up because there was some confusion when I was talking with some people about it today, and I think this is something I'm going to have to ask the instructor about, because when I asked, the person I talked to they did not have a solid enough grasp of it to be sure when they were talking to me. So I think I am going to look it up now, and then I'm going to ask the instructor about it on Monday. Hopefully we get done with the exam early and we can start practicing in the lab. Cool, cool, cool. 5 chamber, not quite yet. Still in the RVOT. And that is the continuous wave Doppler. I'm pretty sure it's this one. Okay, so the PI end diastolic volume is the end of the gutter of the insufficiency. And the pulmonary velocity max, or pulmonary valve velocity max, is a different point than the gutter. And I did not put a comma in there. So okay, so the normal pulmonary velocity is 0.6 to 0.9 meters per second. And it should be down because we're looking at the outflow tract, which means I'm trying to think if there's a way I can explain this that would make any sense at all. Okay, so the squeezy pouch is up here. The baseline is here, right? So if the squeezy pouch is here and it's blasting blood this way, then you're going to have a wave that goes like this underneath it. And if this valve right here is not good enough, you could have insufficiency or regurgitation if you're talking about like the tricuspid valve or the mitral valve, but this is the pulmonary valve. So this is the blood going to the lungs. So if it goes back up, it's called an insufficiency for some reason. So it goes up and the velocity sort of looks like a roof because it goes down gently, right? And the end of that, the end diastolic velocity is that PIEDV, the pulmonary insufficiency and diastolic volume velocity. The velocity, not volume. And the PV max is the normal, that's like what it's supposed to be. So the PV max should be beneath it. It should be below the baseline, and the insufficiencies should be above the baseline. So I think I answered my own question. But 2/3 in the middle, but 400 above, I think that's what we've got. I think that's the question I'm going to need answered. 400 above, 2/3 in the middle, which I know doesn't make any sense, and I am very sorry about that. But in order to explain it, I would need more time. And I feel like there's already so much to do that spending the time on that might not be the best use. Unless you would specifically like to know. And you can ask me and I'll explain it. Okay. So, PIEDV. Probably on the QRS, I would think. Somewhere around there. I should have taken note on what the buttons are, but I feel like this is fine. Just so long as I read carefully. Oh, that's pulmonary. Aorta. You would want 500 above, but I don't think that's the case. Maybe 3? The velocity is not that much. The pressure is not that much. So middle 2/3 should be fine. Okay, I think I got this. Yeah, I think I got this. All right, we're on moving to sax here. That's good. That sounded a little northern. Okay, well, we don't really need that, do we? No, we don't need that. That's fine. Sometimes I forget to sector. Yeah, we don't need that. We know we're changing the view. It's a new section. Okay, so sax base level AOV, zoom AOV, color AOV, tall. Get this out of here so I can look at my notes. Is there anything I forgot? No, we're good. We're gonna continuous wave through the tricuspid valve for tricuspid regurgitation. That is green still. TRV max. And that is a 0.300 below. So our regurgitation is going to be actually below the baseline this time instead of above the baseline, I think. Yeah, it's going to be below the baseline. Because it's going that way. Because we're looking at our atria, interatria septum, which I always forget to color. Atrial septum. I'm a rainbow you. Let's do pink, purple, and blue. And orange. We have to color the interatrial septum. Why aren't you being green? Be green. Be green. Lame. Whatever, it's fine. So I gotta color the interatrial septum, which is very rainbowy. And I always forget to do that, but you have to do it in order to see shunts in case there's a hole in your atrial septum. So now we got rainbows. That'll pull my eyeballs. All right, then we're gonna go to the RVOT. Oh, I guess that would be the RVIT that we were in. Whatever, it's fine. I know where I'm supposed to go. Oh my gosh, Kitty Cat, calm down. What are you doing? Slow your roll, kitty cat. Meow, meow, meow. Okie dokie. More grapes. There you are. Hi. Yeah? Did you come to say hello? Why are you tearing up on the carpet? Are you mad? Oh. Facing away from me, you mad? Why are you mad? What are you doing? Come on. Tracks. She gets upset when I don't come to bed. Because she gets pets when I go to bed. What happened to you? It's like you like me now or something. Yeah, you like me now. I like you too. Yeah. Is it because I give you lunch meat? I'm not going to say the word because she'll think she's about to get in and I don't want to ruin her day. She's already grumpy though. All right, our pulse wave is, what do we decide on? Blue? Teal. Okay, RVOT, PV, that's blue. And where are we at? We got we're gonna color this and try and get in our main pulmonary artery if we can. Some people you can get that, and some people it's a little bit more difficult. 2/3 below. Do we have a thing for VTI? No, we're just coloring what we're measuring. Okay. Well, we're measuring our VTI. Do we do RVOT VTI? Yeah. RVOT VTI. Our acceleration time. And that is base to peak, obviously. 2/3 below. We got our continuous wave. Oh, this is fine. We can just do that. And it goes through our pulmonary valve, which is blue. Is that the right blue? Looks fine. Okay, then we're going to measure our pulmonary insufficiency and diastolic volume. And our PV max. What way are we going for that one? Because we're in PSAX. So it's down. So our PI is going to be up. Our PV is going to be down. I don't know if that's true. I need to look at my other pictures. Hey, PSAX, what up? I was correct. Good. Little miss, are you pouting or are you guarding? I can't tell. Yeah, I'm pretty sure there's a treat in your treat bowl still. Silly girl. Okay, so that's gonna be 2/3. PV max is gonna be point below, above. Okay, it doesn't look like there's any shirt in. Cool. Two-thirds in the middle. All right, then we get sacs mitral valve. We got color mitral valve. I wonder if there's a rainbow highlighter. Nope. That would be so cool. That's okay. All right, mitral valve, color mitral valve, papillary muscle, apex level. Then we move on to apical 4. Apical 4, increased depth. 4 alive, decreased depth. 2D, decreased depth. Some more. Then we're going to 2D capture. And we're going to review that. And then Simpson's 4-chamber diastole, Simpson's 4-chamber systole. Get the ejection fraction, make sure that's fine. Color our mitral valve and entire LA. Tall. And covering the entire mitral valve. Oh, good. I didn't realize that those were notes that I had written, but I edited them without seeing that they were there, needing to be done. So that's good. I'm remembering. I'm learning. All right. Pulse waving. And our pulse wave is the blue. Ish. Our mitral valve didn't get a color, I don't think. Well, that's unfortunate. I feel like mitral valve should be blue, but if we were looking at the aortic valve should be red if we're going to do that. The mitral valve should also be red. But in my brain, it's got blue. Just like continuous wave is yellow. But I can't do either of those because blue is already the pulmonary valve. Which should be purple, but it's too close to pink because I can't use yellow. Okay, A point, deceleration time, and the A duration. Continuous wave. Above the baseline for mitral stenosis, 2/3. Below the baseline, greater than 500 for regurg. Pulse wave. Now we're doing TDI. TDI's got to have its own thing. I think TDI should probably be something. I mean, purple would work for TDI, but TDI is going to be red because TDI is red, blue, and purple, and it looks like a rave. So, medial E, lateral E. Pow, pow, pow. Then we're gonna zoom the left atrium. Did I miss the interatrial septum again? No, that's down there. That's good. Okay, so we're gonna zoom the left atrium, take a picture, then we're gonna zoom back out, and then we're gonna trace. Why are there two? Color the pulmonary vein. Then we're gonna go pulse wave that pulmonary vein. Pow, pow, pow. SDA, a reversal, which is the atrial kick. Pump it back up in reverse. And when we are done with that pulse wave one picture, where do we want to be for this? Do I have that written down? I don't. I guess the middle. Middle's fine. We'll do 2/3 in the middle. That sounds right. I'm gonna trust my heart. We're getting slappy. Zoom, interatrial septum, color interatrial septum, zoom, IVS, color IVS, sector width on right side, live 2D image, freeze and scroll to end diastole, RV base diameter, RV mid cavity diameter, and make sure they are diagonal. Diagon alley. Oh, it is 2/3 middle. Look at that. I followed my heart and I was right. It's in my notes. That's great. That's great. I love that. Okie dokie. So we're going down burp burp derp. Sector continuous wave on the tricuspid valve. And we've got a TV. We got a color TV. Then we're going to do our TRV max to calculate the right ventricular systolic pressure. I think that's just the same thing. 300 below the baseline with that measurement. Yep. Okie dokie. Then we're gonna M mode. We should have a special one for M mode too. Yeah, we're going back up to the top for that. Because TDI's got red. Yeah, because M mode's important. And it's a specific kind of measurement. So it should get its own color. Maybe it should be orange. Nothing else is orange. And mode's gonna be orange. I hate that, by the way. I hate that. But that's what it's gotta be. I only have so many options. not doing M mode on the mitral valve in PSAX anymore, so that's nice. That saves a little bit of time. TDI is red. Okay, so we are on the right side of the heart in 4-chamber still. We're going to continuous wave the tricuspid valve, and we're getting below the baseline 300 tricuspid regurgitation if it's apparent. And that is a point. And that's going to be mid-systole, because that's when that's going to happen. Then we are going to M mode the right ventricular free wall annulus for TAPSE. TAPSE. TAPSE's getting a green too, because the free wall annulus is part of that structure in my mind. So TAPSE gets a green. And this goes with that. So we are going to back this up. And yeah, just because I don't want that. Not can measure off Zoom. Definitely do measure off Zoom. Do not measure on Zoom. Do I have anything else that says can? Yeah, okay. Alright, that's fine. Gross. We're just gonna put the volume, because I'm not gonna. It's fine. That's a thing for me to glance over to make sure I'm not like out in left field with this anyway. Okay. Then we go to apical 5. We take the initial depth. Don't give a crap about the right side, but it needs to be there. You don't have to see it. There can be a rib in the way or whatever. It doesn't have to be well visualized, but it has to be on axis. And we're going to zoom the left ventricular outflow tract and the aortic valve. We're going to color them tall, slim. Oh, I should add tips for that. Else. Okay, back to the good stuff. Pulse wave. Continuous wave. Okay, so for pulse wave, we're going to trace the LVOT, VTI. I don't have a special color for that. All right, we're going to measure the pressure half time, 2/3 below, then 4 to 5 above. And we're going to pulse wave again. This time we're going between the aortic valve and the mitral valve. Yeah, that says MW. That's definitely supposed to be MV. How does it say W? Typo, I guess. IVRT. I heart you. Just relax. Relax. Don't do it. Okay, so the IVRT, we increase the sweep speed though, I think. Ah, yes, we do. 2/3. Increase sweep speed, all caps. Okay. I forgot to do that last time. 2/3. Okie dokie, so now we're in apical 2. We want to decrease our depth. 1/3 of LA is showing the left ventricle and the mitral valve for EF measurements. Capture and review. Simpsons. 2-chamber volume. Distally and systole. Color. Mitral valve and the left atrium. Color. Continuous wave. Continuous wave mitral valve. Is that it? It's that we're not pulse waving then. Okay, cool. 2/3. I've got here 500 below. Do we want that? That would make it so small. And also, like, no. That would make it so small. Why does it say 500 though? I mean, is it just because it's the mitral valve? God bless it. Alright, whatever. I'll ask about that one too, I guess. I think it's just 2/3 though. Because this is a secondary view to back up whatever we saw in the first one. So if we saw regurgitation in the first one, or if in the color we see a flame, we can do that. But I think they just want the 2/3 above and below the single picture. Okay, so, oh, no, not that. It's fine, I guess. I'm backing up anyway, but. Okay. Measure off zoom. Alright, apical 3, we got continuous wave here. Do I have anything else for that? No, we're good with that. Above 2/3, below 500. Zoom, LVOT, AVO, color, pulse wave. We're going to get the VTI for that one. And then we're going to continuous wave the aortic valve. And we're going to get the halftime, 400 above, VTI, below start. QRS to after T. Who's trying to talk to me? Nobody's trying to talk to me. All just group chats. That's fine. Okay, okay. Then we got continuous wave. Oh, for the tricuspid valve. And the RVIT. Don't forget to do that. I don't think I will. I mean, I never have, but I'm just so paranoid because it's like a hidden view. It's not something that's like super apparent. You have to know exactly what you're looking for. I'm so paranoid that I will forget it, but like I said, I never do. So, okay. So, got that. Now our subcostals, which I'm super good at it because I'm awesome. But let's go over them anyway. So we've got subcostal, depth decrease, depth increase, zoom, inner atrial septum, color inner atrial septum 38 on the color scale, zoom IVS, color IVS with as many pictures as you need. Then we put our color scale back, then we 2D the IVC, normal respiration, then we annotate sniff and increase the number of loops to 5. We'll have an eyeball for this one. Eyeball should be up here. IVC with normal respiration. And this is also supposed to be a box. Annotate sniff, increase the number of loops to 5, measure IVC diameter. Should be greater than 50% with inspiration. Directly to the left of the hepatic vein. Color the IVC in the hepatic vein, pulse wave the hepatic vein, showing above and below the baseline. That's going to be a 2/3. (2D) descending aorta, color descending aorta, pulse wave descending aorta. 2/3, take the picture. Up to the suprasternal notch. I wonder if I can get rid of some of this so I can get it down to 6 pages. Maybe I should go to 11 font. 2D SSN aortic arch. Color the SSN, both sides individually. A continuous wave ascending, continuous wave descending. Pulse wave descending. As low as you can go. And that's it. I brought it down to 6. I don't really need that. That looks fine. Cool. I like it. I think I'll save it. What time is it? Almost 9 o'clock. Been doing this for 3 hours. Cool. Love that for me. Oh, I didn't have it on an automatic restart. That's fine. The credit I got was in the knowledge I gained. Okie dokie. Well, I think that's a good place to let it off. It's literally hitting the 3-hour mark in about 30 seconds. So thank you for coming by and hanging out with me. Super nice of you. I hope that you had a good, nice educational time. Congratulations, because this is not actually going to be a VOD, just because I included homework things, you know. I don't really want to be doing that for something that's just like available out there. I don't want to be part of that. You know what I mean? But hey, we got a decent amount done. I feel like the amount of studying I've put into the lab alone is, I can be proud of that. I've put so much work into that class. I mean, yeah, I've worked on the other classes, but I feel like there's a special kind of effort, a special kind of accomplishment that you get when you are working on a class that you're not just like good at. You know, like I'm good at it, but some things just take so much work because they're just so hard. And we're gonna get through the other side. I'm determined. I am so determined to put myself in a position where I can help as many people as possible. And I think that that's been the case my entire life. And I've helped a lot of people so far. And I think that working at the hospital for as long as I did in the pediatrics, I helped a lot of kids, a lot of adults, and I did a lot of good there. And when I was teaching in adult education at a school that charged the least amount of money possible in order to get through the program, like I was making a very small amount of money. It was bad. It was bad. I was getting paid really, really bad, and I had no benefits. But every single person that I helped graduate and get like nationally certified in the things that I helped them get certified in, they didn't just remove themselves from the economic station that their parents had been in and that they were in. The people that benefited from them having that education and being able to help people, that was huge. I love teaching. Love that. But I also would very much like to be able to make enough money so that I don't have to worry about if I'm going to be able to like have a house or an apartment or just like someplace to live when I can no longer work. Like, you know, like I want to help people, but the way that things are set up in this country, the willingness, the ability, and the drive to help people does not help you sustainably. So you got to go through specific routes if you want to do both. You have to go through very specific routes, and I am so fortunate that I'm able to take that route. Which is another reason I can't fuck this up. I don't want to ruin, the opportunity I've been given. I don't want to waste it. All right, goodbye forever.